All right. Well, welcome everybody. This is a hip information education class. I'm just going to be presenting some basic information about what you guys can expect when you come in for surgery to have your hip replaced, ways that you can prepare, things that can be done ahead of time at home, and what to expect once you're in the hospital, and how the progression goes after you're home for your recovery. All right, so as I said earlier, please just raise your hand if you have questions as we go through. It's not a huge presentation. We should be done before 2, and we'll have time for questions at the end as well if you want to hang on to your questions until I'm done with the presentation piece, okay? So we're going to follow the handout with the boxes. It's got the slides on it, and we'll go through. We'll just start off with some basic information. Myself, my name is Vicki. I'm an occupational therapist. I work on the orthopedic floor, so I'll be seeing many of you, I'm sure, in the next little bit when you come in for your surgery. You'll see both an occupational therapist and physiotherapy in addition to nursing, your surgeon, all those folks when you come through. The physiotherapists will be looking at your mobility, your transfers, getting in and out of bed, your exercises, all those kinds of things. The occupational therapist, we will see you maybe at home before you come into surgery, for someone from home care. And then I will see you here at the hospital to look at your functional stuff. So after your surgery, how are you going to get in and out of bed, use the bathroom, get yourself dressed, more of the nitty-gritty functional kinds of everyday things that you do for yourself. Okay? Any questions so far? Any specific things that you want to make sure that you learned today or that I touch on information-wise? We're good? Okay, so we'll get going here. So I'll just start off with a little bit of anatomy. You may or may not have gotten a bit of this information going through the clinic process at NEJAC. But just to have an idea of what's where and what gets replaced. The left-hand picture here is just showing the hip joint. It's a ball and socket joint. The top part of the leg bone has got the ball on it, which fits into the cup or the socket in the pelvis. It's called the acetabulum. And on the right-hand side, you can see in the little box there in the picture, it just sort of shows you what the arthritic process is, what happens to the joint. Normally, all the joints in your body are nice and smooth. There's cartilage covering both surfaces, a little bit of synovial fluid in there to make it nice, good, full range, pain-free. When you have when the arthritic process takes place, you lose that cartilage. It wears down in places. Sometimes it can completely wear off, and you end up getting bone rubbing on bone, and that can lead to a lot of pain. People get pain. It can be referred. It can be right in the hip joint. A lot of times it can go into the groin, down the leg. Either way, it ends up limiting what you can do, how you move, and the things that you're able to do for yourself. You can also get what are called osteophytes, which are those little outgrowths, the little red outgrowths around the edge of the ball there as well. So they do try and manage that, contributes to the process as well in the pain process. Okay. So what gets replaced is what they do is they take off the top part of the femur, so the neck, but right between the leg bone and the ball. They take that piece off and replace it with the ball and a stem. So the prosthetic comes in 2 pieces, actually 3. The stem goes down into the leg bone. The ball gets completely replaced, so this is attached onto the neck. And then this piece is what goes into the pelvic cup portion or the socket portion of the pelvis. This is lined with what's called a polyethylene. It's a plastic liner. So it's nice and smooth so that you get the pain-free range, smooth range of motion. And the ball is usually this part's titanium, stainless steel for the ball, titanium for the cup. They do sometimes use other materials, but that's typically what gets used. And it goes into the joint like so. You'll notice that, I'll pass this around, you guys can have a look at it. The surface of the metal here is textured, and that's so that the bone can actually grow right into the spaces in the metal so that you get a nice, good, solid joint once it heals. Okay? I'll let you have a look at that if you want to pass it around. Yeah. Any questions about that? So far, so good? Okay. And this just shows what it looks like on x-ray. So you can see the hip joint. This is a person's, if they're facing forward, the right hip. You can't really see the ball because it's up inside the socket. Okay, typically what they do is what's called a press fit. They don't always, sometimes they use glue, but not always. They press it into place, both of the pieces. And the far picture is a picture of just the angulation. So if a person's lying down, the joint is actually angled backwards just to mimic the natural joint. They will pick a prosthetic which fits you. They come in all different sizes and shapes and angles. So the surgeon will know ahead of time from your x-rays what size you're going to need. So they will pick whatever is going to match your other joint, basically. Okay, so because of the nature of the surgery and how they have to go in through the connective tissue, the soft tissue, and the muscle to get to the joint, it's what's called a lateral approach, typically, is what the surgeons do. The period after surgery, you need to be a little extra careful because of the soft tissue that while it's still healing, we want to reduce the risk of dislocation. The risk is actually very low to start with, but just to make things extra safe and while you're still healing, while those muscles are still healing, we teach everyone what we call hip precautions or movement precautions. And these are things you want to be careful of just for the first 2 to 3 months. Your surgeon may allow you to do some things sooner than others, but there's 3 main precautions that we teach everyone. All this stuff is in your guide and will help remind you once you're here in the hospital. But basically what it is no bending past a 90-degree angle, so that would be the middle picture. You don't want to cross your legs, cross your ankles, or twist your body on your leg, or twist your leg on your body. All right, so it has some functional implications in terms of how you move, how you do your everyday activities, those kinds of things. So I'll talk a little bit more about that. It also means that you might need some pieces of equipment at home after the surgery as well, just to reduce the risk of bending too far. That's probably the trickiest one for most people, especially once you're healing. You don't have the pain anymore, but you still have to remember, oh, I can't reach down to the floor. I can't bend down to my feet or pick up something, okay? So those are the main 3. It's whatever your joint is going to be able to accommodate. As long as you do your exercises and stick to, the protocol and what you're supposed to follow in terms of strengthening and walking and all of those things. And then after the 3-month period, or it may vary depending on how your surgery goes or what your surgeon wants you to do. Always follow what your surgeon says. This stuff is more of a rule of thumb. We tell everybody 3 months at the most, okay, for these things. Okay, I'll talk a little bit about what we call ADLs, or activities of daily living. Those are the sort of the functional things that I was telling you about earlier. Because everybody probably pretty much has an idea, you're going to need at least some equipment for home after the surgery. There's 2 categories of equipment. All right, so that's the main thing we want. The take-home message for today is to be aware that you need some large pieces of equipment and some small pieces of equipment. All right, the larger items, which typically you can rent from home care, those include things like your walker, raised toilet seat, something to sit on in the tub, those kinds of things, bed rail, those kinds of things. Home care will rent to you for, I believe, up to 8 weeks. Okay, you don't have to worry about getting it ahead of time, or unless you really want to own the pieces of equipment, you can purchase it ahead of time, but home care can bring all this stuff for you, okay? Yeah, we have 30 days. I believe it's still 2 months, but they'll let you know when they come to see you. And they'll arrange that for you ahead of time. What they try and do through home care is an occupational therapist like myself would come out, would call, make arrangements to come out and assess your home, see how many stairs you have, are there chairs that are high enough for you, how is your bed, those kinds of things, what do you need in your washroom in terms of raised toilet seats and those kinds of things. And they will do the assessment, go over some of this information with you, and then they'll order you the equipment as long as they have enough time in advance of your surgery. If you if you get your surgery at the last minute, we'll help you here from the hospital get your stuff. But if they have enough time to come and see you before your surgery, they'll arrange everything for you and make sure the equipment is in place in your home before you even come. They usually do it right before you come to the hospital, okay? Or while you're in the hospital if there's somebody who can be home to accept delivery, okay? So that's all the large stuff. And And what happens, and just so you're aware, the referral process is initiated when you come for pre-admission, okay? Has anybody here been to pre-admission already? Pre-admission, a few, okay. Yeah, so that's the whole process where you come in and have x-rays and talk about anesthesia and pain medications, those kinds of things, blood work and whatnot. That will initiate the home care referral. So the home care will know that you're coming through the system, and they will get in touch with you to set up the home assessment with the therapist. All right? But like I say, don't worry if you get a last minute surgery and they can't make it out to your place. We'll just order it for you from the hospital and they can still deliver everything. Okay? So that was the first category of equipment, the larger stuff. And that's those, there's some, actually I have some pictures here. There we go. Okay, so raised toilet seat, walker, your basic things just to help with your mobility in the home and make it a little safer. So the second category of items that you're going to need, that are things that we call assistive devices, and these are just little gadgets that are going to make your life easier and make you be able to be independent with your daily activities, so getting dressed, getting washed, those kinds of things, okay? So this would include items such as a reacher or a grabber. If you're sock aid, if some of you are familiar with that, everybody asks me why they didn't have that already for the past however many months, because I know everybody has trouble getting their socks on. Or a lot of people do anyways. Long-handled shoehorn, sponge, long-handled shower head is a nice thing to have as well. You don't have to, but it is nice if you end up sitting on a seat in the tub, you can at least sort of direct where you're washing with a handheld shower. Okay, I'll show you, I brought some examples so you can just have a look at what these things are in case you haven't seen them before. And these you can pick up at any medical supply store. PharmaSave, up on LaSalle, Shoppers Home Health, there's a few in town here, Motion Specialties, they all have this kind of stuff. So if you only get one thing, this is going to be your friend. It's a reacher or a grabber, so that you can pick up stuff off the floor. You're not allowed to bend to the floor. You can't bend down to get your pants, underwear on, that kind of stuff. So this is what you're going to use for that. So like I say, if you only get one thing, I would strongly recommend that you have one of these to keep handy. Some people have multiple ones. They keep one upstairs, one downstairs, so that you've always got something to use.
They have them at dollar store for $2.50.
Yes, there you go. The best deal, $2.50 at dollar store. So yeah, they come in different shapes and sizes, but you basically want something that you can pick things up. And these ones are nice because it's got a small end to it, so you can get fairly small items up off the ground. I think there's a magnet on the end too. Okay, so that's the reacher or the grabber, which makes life easier. Long-handled shoehorn, so you already probably have one of these, I'm guessing, yes. The trick with the shoehorn is you do want to make sure it's a long one so that you don't have to bend over. Sometimes people have the little bitty ones, which still means you have to bend over too far to get to your feet, okay? Long-handled sponge, nice to have, not absolutely necessary. And the other item, which is handy, is a sock, what's called a sock aid. Anybody have one of these? No? Haven't seen one of those? The way it works, let's see here. Somebody left me a balled up sock, just like at home. Okay, so you just throw your sock on like this. And it's got long handles, so you just drop it down to the floor. You don't have to bend over. You put your foot in it, and you just, it'll pull your sock on. Okay, so it's a very handy gadget. It makes it easy. Some folks would rather just have help. My husband or my wife can help me do my socks, and that's totally fine. But if you think you might need to be able to do this on your own, if you're going to be by yourself, that's a handy thing to have. We also sell all 4 of those items here at the hospital. So if you want to just wait till you come, you can buy it all together as a kit. So we have them here too. So it's totally up to you where you want to get those. Any questions about the equipment, the gadgets? Pretty straightforward. Okay. So that's just showing you pictures. There's different kinds of sock aids, but they all work the same way. Some of them are flexible. That's what the one in the picture is here. Using a reacher to get stuff off the floor. You also use it to get dressed. So it's a handy item. So I'll talk a little bit about getting prepared at home. And I think I had already mentioned a home care occupational therapist will be coming, will try and make it out to your place to assess and figure out what equipment that you're going to need. or else we will order it from the hospital. You want to think about safe access, easy access to where you're going to be in your house, where you need to go. It's great if you're in a one-floor home or a bungalow where everything is on one floor. But stairs, you will be able to do some stairs when you go home. By the time you go home, the day before, the day of, you'll practice some stairs and you'll be able to do at least a few. You just won't want to be going up and down the stairs, multiple times a day to access a washroom, for example, right off the bat when you get home. So give some thought to where you want to stay. If you only have a washroom that's upstairs, you might want to stay in a bedroom upstairs for the first day or two, so you have access to the washroom. Okay. You'll be using a walker, so you want to think about having enough space to get around. The regular size walkers will fit through pretty much almost all doorways, unless you have particularly narrow ones. But you want to make sure there's no tripping hazards, no rugs, cords on the floor, those kinds of things, because your mobility will not be 100% when you get home. Okay. Think about the other things that you need to be able, that you normally do: making meals, cleaning, household stuff, transportation. Who's going to help you with those things? Lots of times people will put meals in the freezer, things that they can just microwave so they can have some easy to prepare meals. Yeah.
If you can't, then can you sit in a car? How do you sit in a car to go home?
Okay, I can talk about that. I don't wonder if there's a better spot. Doesn't really matter. The question was getting in and out of a car to go home. It all depends on your height versus the height of the seat of your car, or the type of car that you have. Most people of average height, I would say between 5 feet and maybe 5'10", are fine with your regular sedan. If you're a close to upper 6 feet person trying to get into a little bitty sports car, then you're going to have problems. The whole idea is that you don't, and it's a really good idea to try if you're concerned about getting in and out of your own vehicle, because you'll be having somebody come to pick you up when you go home. So give some thought to it beforehand. Who's going to come get you and what car? Who's going to use what car? But the whole idea is that you're not bending too much to get into the vehicle. All right, so if this is the passenger door, I recommend you get into the passenger side. You can push the seat all the way back as far as it'll go. You can recline the back of the seat, because the whole idea is that you don't want to bend past 90. I'm fine like this. This chair's not very high. So as long as you're leaning back a little bit, you're okay. I'm okay up to about this 90 degrees. As soon as I have to bend my legs to get my leg in the car, that's too much. So as long as you're kind of leaning back a little bit, and the other alternative would be to go on YouTube. There's lots of videos on YouTube. Just put in a search for hip replacement car transfer, and you'll find all kinds of videos that actually show you the safest way to get in and out of a car. Okay, you sit with your back to the car. This is the door here. Ignore this guy. You're just going to scoot back and swing your legs in. You might need help to swing your legs in, it depends. But the whole idea is just that you're not bending too much. And as long as you're not bending, you're good. Sometimes people put a cushion in the seat to make it a little higher. That's the other thing that you can do. Especially if you're not real tall and the truck is really high. Yeah, that makes it a little trickier. Okay. Where were we here? Easy access, arrangements for meals, yard work, those kinds of things. You won't be able to drive, all right? You won't be allowed to drive for at least the first 6 weeks. And it may take longer, especially if you're having your right leg done. More so just because you'll still be on some pain medication. Your mobility, like I say, won't be 100% back to normal just yet. So you want to wait till you're cleared by your surgeon to return to driving. You'll see the surgeon at the 6-week mark for follow-up. So you'll just need to think about who can take you to appointments, those kinds of things. And you'll want to, with respect to your home, set up a recovery center. Again, think about where you're going to spend your time for the first little while. You will be mobile, you'll be able to get around, and you'll be able to do a few stairs, so keep that in mind. If you live alone, this is very, very important. We strongly recommend that somebody either come to stay with you for the first little while, or that you go to stay with someone else. Especially say if you have like a side split with lots of stairs, is there somebody that you could stay with for the first little bit? Just to have somebody around. The other person doesn't need to help you move or pick you up or get you in and out of bed or anything like that. It's more just for answer the door, answer the phone, meals, those kinds of things, just for a little bit of supervision. Okay. Oh, and a little bit about arm exercises. Sorry, that's at the very bottom. You might not be able to see that. You'll find when we get you moving in the hospital and when we are helping you get in and out of bed, up and down from a chair, you're using your arms a lot to scoot, to get yourself up to standing. So we always recommend that you try and do a few little arm exercises in advance just to get your arms a little stronger. And so we recommend you do some what are called arm push-ups. Find a nice sturdy chair with armrests, and all you're doing basically is just lifting up the weight with your arms, okay? So just to kind of work the muscles here, because those are the ones you're going to be using to get yourself in and out of bed, up and down from toilet, chair, so forth. And if that leg isn't able to, if your operated leg isn't able to help as much, you're only using the one leg, so you're going to need your arms a little more than usual, okay? Okay, so getting ready to come to the hospital. Definitely bring your guide handout. That's the colored one. We can just call this the guide. So bring this guide with you so you've got all your information in case you need to refer back to something. It's got all your exercises in it. They'll be doing those with you while you're here, so you'll have that handout with you. Bring your toiletries, toothpaste, those kinds of things. Shoes, slippers are important. You want to have something that's good for walking. Once we get you up and moving, you want to have some slippers or shoes, whatever you prefer, that's got a closed heel and a solid heel as well. Nothing too tight. Most people tend to get a little bit of swelling in the operated foot. So if you have slippers that are already snug, you might not be able to get them on after surgery. So something that has a little give to it. Loose fitting clothes if you want. You can bring pajamas, loose pants, tops, bathrobe, whatever you feel like you're going to want to have. Lots of times people are happy with just the hospital gown. That's fine. But you might want to bring something just to keep warm when you're up moving around. Okay? And stuff to do, reading material, puzzles for the down times in the evenings when it's quiet. It's busy during the day, but later in the day you might want to have some things to occupy your time. The very bottom here is the website for the guide as well. So if somebody else wants to have a look at this information or print it, you need to print it off again, that's where it's located. Okay? Hospital stay. Okay. So for hip replacement patients, you follow what we call a care map or a care plan, where specific things happen each day. They order specific things for your treatment with nursing, with your medications, with other things. And you go through the progression. Each day is sort of dictated what's supposed to happen, okay? In terms of and also in terms of how you're moving, what the progress needs to be. So you'll be here 3 to 4 days. We're aiming for 3, but if you really need the 4th day, it's there. So if you come in for surgery on a Monday, we call that post-op day 0. That's the surgery day. Post-op day 1 will be Tuesday. Day 2 will be Wednesday. Day 3 will be Thursday. So if you come in for surgery on Monday, you'll most likely be going home Thursday if you're moving well enough. Okay. You'll bring in your toiletries, shoes, clothes. As I mentioned, you'll go to registration, which is the same place you go for pre-admission. And they'll set you up because you've already gone through the pre-admission process. They take you straight to surgery, which goes for about 60 to 90 minutes. And from there, you go to the recovery room, or the PACU, and you're there for a few hours just while they monitor you while you come out of the anesthetic. Okay. Anesthesia-wise, they'll discuss that with you in pre-admission. But for most folks, they're not doing much general anesthetic anymore. It's a spinal anesthetic, which tends to have less side effects and people recover a little faster. So they'll talk to you a little bit about that as well. Okay. Just for your own information, visiting hours are now 9 a.m. to 9 p.m. So folks can come anytime, although I would recommend on the floor, things are very busy in the morning. Morning is not the greatest time to have people coming in. The nurses are working with you. They're changing your dressing. You're getting a bath. We're coming to bug you. So there's lots of stuff going on in the mornings. Afternoons tend to be a little better, or evenings better still because it's quieter then. Okay. We squeeze a lot of things into the 3-4 days that you're here. So it is, like I say, it is quite busy. So I'll just to go through the days when you're here. So we start with the surgery day. You stay in the bed for the rest of the day. So technically you're on bed rest the day that you have the surgery. But you will be shown how to do some breathing exercises. Anytime you have anesthetic, it depresses your respiratory system. So you want to make sure that you're getting the lung function back and the breathing strength back. So you'll be doing deep breathing exercises. You may be given a little blue contraption that you blow into, and that's to help with your lung function as well. Some things to prevent blood clots. All right, since clots are a risk with any kind of surgery, they do quite a few things to try and combat the risk of blood clots. So we want you to be doing some ankle pumps. You can't do too many of them. A minimum of, a whole bunch every hour, 10. I forget now what the physios are saying, but you can't do too many. So trying to remember every hour. And ankle pumps is all it is you're just lying in the bed and you're moving your ankles up and down, circles, whatever, however you want to do it. But that helps with the circulation in the legs to mimic vascular return that you get when you're walking, okay? You'll have some stockings, the tall white stockings. Those also help with the venous return when you're in the bed. You'll have a dressing, possibly a drain. Not very often the drain. Bulky dressing, you'll have a catheter. They take that out usually the very next day. So you just have it the night of surgery, and the next day they take it out once you start moving. They do recommend, the nurses will push fluids. You want to keep drinking and make sure you maintain your fluid intake. Because you've been NPO for the surgery, we want to regain some of that fluid to maintain your kidney function. Okay? So the next day, day one, at the very least, we get you out of bed to a chair. If it's not first thing in the morning, we definitely aim for lunch. Sometimes people have different reactions to the anesthetic. You may have nausea. You may not feel it will be sore. But if you can tolerate it, we get you out of bed to the chair. You'll start your exercise program with physiotherapy. They'll come by, show you your exercises. They'll do them once with you each day, and then you're supposed to do the ones you're able to do by yourself another couple times a day. The occupational therapist will come, myself or the other therapist. Her name is Jill. And we come just to check out and see what you've got. If home care came, did they bring you your stuff? Is there anything you still need? And then we figure out how you're moving, how it's going to go. Is there anything else that we can help you with in terms of equipment, bathing, dressing, that kind of stuff. Days 2 to 4, 2, 3, and 4, you'll continue with your transfers, getting in and out of bed, walking to the washroom. You'll progress to walking out in the hall. We'll come and show you how to use these fun gadgets so that you can know how to get yourself dressed independently. And then if you are still needing some equipment at home, the CCAC or home care will be in contact with you to figure out when they can bring stuff before you go home. Okay? I think I mentioned earlier, so for discharge, we'll have an idea of, in the first day or two, what day you might be able to go home. So have your arrangements ready for your ride home. And they do try and, we try and have arrangements for home in the morning. So we aim for 10, but for sure before noon on the day of discharge. So folks get really worried about when we talk about the hip precautions and what you're not supposed to do, and people get really worried, oh my gosh, I bent too much. Try not to be too anxious about it. We help you when you're here in the hospital. We help, make sure you're remembering how to move. But if you bend a little too far one day, your hip's not going to come apart. It's if you start bending too much or doing those things habitually and too far, then you might be putting yourself at risk, okay? So we just like everybody to keep those things in mind, especially for when you go home and you don't have as much pain. That's the time where you need to make sure that you're reminding yourself for following the precautions, okay? So positioning in the bed, as you can see, our little guy here on the left, what's he doing? What's he doing wrong? He's reaching for his blankets. Anybody say? He's bending too far. So if there's something you can't reach and it's over there and you don't have a reacher, ask for help. We'd much rather come and help you with those things and grab you what you need than you taking the risk and trying to do it yourself, okay? So when you're in the bed and you're sitting in that position, you're always wanting to be leaning back a little bit. This is how you're going to be trying to scoot yourself in and out of the bed, just so you're leaning back and so that you're not bending the hip too much. On the right-hand side, we don't want you lifting that operated leg right up off the bed. Puts a little too much strain through the joint. Again, when you're getting out of the bed, we're here to help you. The nurses will help you move that leg, okay? Because it's gonna feel really heavy and difficult to move the first few times you do it. So, you know, we'll either help you move the leg or we get out of bed on the good side, whatever works, okay? They will position your leg up on pillows. So you'll have a couple pillows under that leg to help with swelling, and it also sort of reminds you not to cross your legs as well. Okay, that's what our guy at the bottom there, he's got a pillow between his legs. You don't want to let the foot roll too much in or too much out. The rule of thumb is as long as you sort of keep your toes pointed either towards the ceiling when you're lying down or forwards when you're standing up, okay? Just so that you're not twisting. Any questions about that, the positioning stuff? No? Okay, so it's just showing the progression of getting in and out of bed. You can see you're needing to rely on your arms to scoot forwards and backwards. Sometimes people have a bit of trouble getting that leg up into the bed. So there's a few ways around that. You can always use a cane or a strap. For sure it's difficult the first couple of days. If by the time you go home you're still having a bit of trouble getting that leg in and out of the bed, we'll show you some other techniques that you can kind of cheat a little bit until that leg's strong enough for you to move it yourself. Up and down from a chair, same thing for the toilet. You're always going to push off from your surface wherever you're sitting. So you're going to push off from the bed, push off from the toilets. There's always armrests next to them, rather than pulling on your walker, because the walker's going to move. If my right hip is operated on, I'm going to straighten out this leg, just because it opens up the hip angle. This guy's going to be bent. My left is bent more than the right when my leg is straight. Okay, so that's why we tell people to stick out that foot. Gives you a little more leeway to lean forwards, so to go to stand up. Okay, and then you grab your walker. Positioning for mobility, so like I was talking about, getting up and down from the toilet. A lot of residential toilets are quite low, or tend to be, especially if they're older toilets. There are newer, taller toilets, which are great. More and more people have them now. So you may or may not need the raised toilet seat depending on, you know, your height and what you've got at home. So sort of take note of what your toilet's like and how far you have to bend forwards to get up and down. And then they can figure out what size, or if you need a riser at all. The lady getting into the shower here, she's sitting on what's called the transfer bench. Two legs stick out on the outside, so you sit first, and then you just scoot yourself over. So you don't actually have to step over the side of the tub to get in. So that's a little safer. She's just using a strap to get that leg over the side of the tub.
Can you step over the side to get into the shower?
I wouldn't recommend it right off the bat. You don't want to be getting your incision wet right away anyways. A lot of the time, by the time you're allowed to get that wet, you're moving well enough. Some people do. If you have a walk-in shower, that's usually the best alternative, because then you don't have to step over at all. But talk to the therapist who comes to your house and see what they recommend. A lot of time, it's more because you don't want to end up putting all your weight on the operated leg, either to get in or to get out. You want to wait till the healing's taken place so that you can do that safely without any risk of slipping, that kind of thing. Pardon me?
How long before you can shower?
Technically, now it's up again to the surgeon. You want this, it needs to be closed and after you've had the staples out, which could be 14 or 21 days. You can, although, mind you can put a waterproof dressing over it as well. So that would be the alternative. If you really want to have a shower, grab a waterproof dressing. The nurses can tell you where to get them and what kind, so that it stays dry. You can do that as well. In and out of passenger seat, we talked about cars already, and stairs. We will get a chance to practice some stairs before you go home as well. So if you have stairs you know you will have to do, and you don't have a railing, now's the time to put in a railing. Or if your railing needs, you know, a little bit of tightening or adjustment, have that done before you come in. I always recommend to everybody. It just makes life so much easier when you have a sturdy railing to hang on to.
How big is the incision?
Incision, not ginormous. I would say, you know, I don't see them that much because everybody's got a dressing on, myself, but it's not huge. Yeah, right on the side there. That's the dressing tends to be bulkier than the, you know, once the bulky dressing comes off, then it's not so bad, but it's not huge. Okay. Do's and don'ts. Pain medication, very important. They'll talk to you about pain medication when you come to pre-admission, figure out what works for you, what doesn't. Is there something you've reacted to in the past so they know what's going to work, what's not. But while you're here, it's very important that you maintain a good steady level of pain control, because that's what's going to allow you to get up and move and participate in your therapy. Okay. And if something isn't working for you, or you're having a reaction, or it's too much or too little, they come by, the acute pain service, they will come by and ask you, they can make adjustments. So they will change the dose, they'll change the type of medication. They want to make sure that you're having good pain control, so that you can get up and move, basically. Okay. And I know they do prescribe classes of pain medication that are not the non-addictive, so it's a very low risk of any kind of overdependence on pain medication based on the type of the class of drugs that they prescribe. But pain medications can cause constipation, so you want to fight that a little bit if you can with a high fiber diet. Back to the plenty of fluids as well for that. The nurses will keep an eye on your incision while you're here. They'll change your dressing every day. Once you're home, you want to keep an eye on it. Make sure there's no signs of infection, which would be, increased swelling, redness, drainage, and extra stuff coming out. And if that happens, you want to let somebody know right away, talk to your surgeon, or even come in to the hospital to have it looked at. Because if there's any chance of infection, you want to make sure it gets taken care of right away. It doesn't happen that often, but it's, you want to make sure it gets dealt with. Okay. Change the bandage when necessary. And I'll talk a little bit about that. Home care will come out and help you for the first few times for dressing changes. Usually by the time, it doesn't take long for the skin to actually close up. So there's not a lot you need to do in the way of dressings. You want to follow your hip restrictions, your exercises. The folks here, the physios, make sure that you know what your exercises are, how to do them. You'll continue with them at home. Home care physio will progress you with your exercises. They'll come to your place, make sure that you're doing them properly, and then progress the exercises, move you off the walker onto a cane when you're ready, that kind of stuff. It's important to keep moving, but also mix it in with rest. So do lie down several times if you need to. Elevate your leg if you're having swelling. You can put it up on pillows, that's fine. And I think I had mentioned earlier, you can expect some swelling in the operated leg, and that should go down over time. Okay? Don'ts. We already talked about getting the incision wet. You don't want to soak it. No getting into the bathtub. It's kind of a double no, because you don't want to get it wet and you'd bend too much to get in and out of the tub. But you want it to be closed, well healed, staples out. But while it's healing, you want to keep it covered, keep it dry. You don't want to touch it so you can reduce any risk of infection. No driving for 6 weeks. We talked about that. The 90 degrees, that's your hip precautions. Don't bend past 90 degrees at the hip, or lift your leg past 90. That's the same thing. So if you're sitting in a chair, you don't want to put your foot up onto a stool, or too high anyways, because that's going to bend your hip too much as well. Cross your legs, twist your body. We talked about that. No getting in the bottom of the tub or onto the floor for your 3-month period of following the precautions. So wait to talk to your surgeon at the 6-week mark about returning to driving, depending on how the healing goes and how you're moving, and which side you had done as well. So you need the transportation to get to your appointments. So for follow-up, a home care nurse will come out for up to 3 visits. It's usually not very many, depending on what you need. And then they'll come and remove the staples either at 2 or 3 weeks, depending on the surgeon. You'll go home with some blood thinner medication. They're doing either a small injection blood thinner, or they also have a pill. So it just depends what the surgeon orders for you. You'll have a dressing on your incision. Physio will come. They come around 4 to 6 visits. So like I said, they'll progress you with your exercises and your walking and stairs. The occupational therapist will come as well, just to follow up with regards to how you're moving in the house. Is your equipment all good? Transfers, is everything safe in terms of that? And then you'd want to discuss with your surgeon getting back to driving. Those of you who are working, depending on what kind of work you do, what your hours are like, to coordinate a eventual return to work as well.
After how many months for going back to work? Maybe 3 months?
The question was how long to go back to work. It completely depends on what your work is like. If it's a sedentary desk job versus construction worker on a roof, very different. So you'd have to discuss that with your surgeon. Yeah, and they can give you a better idea of what to expect in terms of going back to work.
Thinking more returning to golf.
Yes, the funner stuff. Yeah, definitely. Okay, but the whole idea. I'm sorry.
Is there adjustments for your swing?
The precaution with golf, I think, would be more the twisting. And so you want to talk to the surgeon because the surgeon knows how your surgery went, how your healing is going. I mean, the idea is that you can do most activities after you're out of the 3-month period. There are some activities that they advise that you not do. And I know there is, we have it in here now, I forget what page it's on, to give you an idea. And I don't remember specifically what category golf is in. Page 18. We have 6 to 8 weeks, 12 weeks, not recommended, and never categories. So 12 weeks, there you go, golf. So 3 months. Just in time for spring. But it's always good to check with the surgeon just in case, but it's not an activity where you end up bending a huge amount, so it should be safe. Yeah, so the whole idea is that you get back to your everyday stuff, the things that you want to do, your regular lifestyle, and you want to avoid complications so that you don't have to come back for any kind of revision surgery, which is pretty rare anyways. Okay? And that's it for our material. Did anybody have questions? Here we go.
How long before you can bend your knee beyond that 90-degree limit?
It's
3 months also?
Your knee can do whatever.
Sorry,
It's your hip. Yeah, that's one of the 3 months. So the 3-month precautions was bending your hip past 90, twisting, and crossing your legs, crossing your ankles or crossing your knees. Yeah, your knee can go wherever he wants. It's the hip you got to worry about. Yeah, for the first little bit. Yeah.
Do you have to use a wedge cushion?
You can. Some people do, and some of the therapists in the community will recommend you have a wedge cushion. It depends, again, what kind of chair you like to sit in at home. If you have a really low chair and it's kind of tipping backwards, we kind of recommend you stay away from low, squishy, lazy boys because you sink into it and you have to really bend forwards to get out. Supportive chairs, taller chairs, anything with armrests is what we recommend for what you use at home. But the wedge cushions are nice because they automatically make you bend less, right? Because your bum's a little higher than your knee.
Yeah.
So they are good for that. Yeah.
Okay.
Yeah.
And what about stopping the blood thinners before
Okay.
surgery?
The question was about stopping blood thinners. They do ask that you discontinue your blood thinners, your anticoagulants before surgery. I couldn't tell you when. They talked to you about that in pre-admission. Yeah. And the other thing actually I will mention as well that I didn't mention already, there is a blood conservation program here at the hospital, which is very useful for those of you who are anemic, who know you have low blood. So if there's anybody who knows ahead of time that they have low blood, you want to call the blood conservation program. The lady's name is Margaret. I can give you her number if you need it. Come and ask me after. But what they can do is set you up before surgery. The more time, the better before surgery to get the iron up in your blood so that you recover better. It's much better for surgery if your hemoglobin, that your blood is in better shape. Okay, so if you know you have low blood or if you're anemic, then that's when you want to talk to Margaret. Okay, yeah.
When do they start NSAIDs after? Because they stop them a week before. So
If you normally take it, yeah, that would be the other thing to talk to at pre-admission. They'll let you know. They give you all your prescriptions when you're here.
after the surgery, do they
They'll
start
let you know
NSAIDs
all
right
that
away?
stuff. Yeah, they'll tell you what you can go back on and what you're not supposed to. It may, I'm not sure. I don't know if you know, Paul, for NSAIDs afterwards? No. Yeah, yeah. It varies, yeah. So it all depends on your own situation and what you normally take and in combination to what else, because you'll have, they send you home with prescriptions for pain medication for the surgery. So you'll have that, so they'll need to coordinate that with what you were regularly taking before. Yeah. Anybody else? Questions? All right. Thanks for coming.
Thank you.